appreciate your participation. My name is Katie Connor, like Allie said, and I work for Indiana Rural Health Association. I have my bachelor's in health promotion from Purdue, Boiler Up. I have my master's certificate in public health, and I'm also a certified health education specialist. In addition, I have Well Coaches certification, which is the gold standard in health coaching. So before we get started, one common thing that I do in my health coaching that I've done for the last 15 years is to, whoever I'm working with, start with 5 deep breaths. So if everyone at your desk can just go ahead and take a few seconds to breathe in and out five times, and then we'll go ahead and get started. Okay, well, I hope that felt good to everyone. Sometimes we don't take time out of our day to take deep breaths, and that's been shown study after study to have a positive impact on our health. Just take some time to take some deep breaths. So today we are going to talk about health coaching and healthcare. How can we bring in health coaching and behavior change models into the clinical setting? Our goals and objectives for today. First, our target audience, who this is meant to be for, is designed to educate physicians, RNs, MAs, LCSWs, or social workers, and any additional clinical staff working with patients on care coordination services, such as chronic care management and behavioral health integration. Our goals for today are to educate clinical staff on how to integrate health coaching with chronic care management, provide tools and resources for efficient and productive health coaching and healthcare workflows, and introduce evidence-based health coaching models, including but not limited to motivational interviewing, social determinants of health, and stages of change. Our objectives for today are for all of you to be able to define health coaching and the role of a health coach, understand the why to integrating health coaching into healthcare, learn the alarming statistics of rising healthcare costs and increase in multiple chronic conditions, become familiar and able to implement evidence-based change models, motivational interviewing, social determinants of health, and stages of change, and lastly, to take away an effective, user-friendly health coaching workflow to adopt into your clinical practice. Our agenda for today, I have 5 modules. Module 1 is clinical health coaching and chronic disease, to give you an overview, a 20,000 foot view of what that looks like. Module 2, care coordination services. We are going to get into the brief overview of chronic care management and behavioral health integration. Module 3 is evidence-based behavior change theories. Module 4, process of clinical coaching sessions. And of course, lastly, evaluations. So our module 1, health coaching and chronic disease, you guys can take a look at the screen. Components, the cost, what is it, what is health coaching, and how do we integrate it? Our objectives are some similar that I talked about of the overview for the whole Lunch and Learn today. Understand the impact, define, and what are our top 10 chronic conditions. So let's first start off with the cost of chronic disease. We may have heard these statistics before, but they're good reminders to hear the reason why we are doing this. The average rate for adherence for prescribed medications is 50%. That means 50% of the population is not taking the medications that we know can help manage and possibly avoid further complications with their chronic diseases. Close to 80% of adults have one or more chronic condition, and even more have multiple chronic, and I think it's around 60% that have two chronic conditions. More than 1 in 3 adults, that's about 92.1 million, have at least one type of cardiovascular disease. About 90% of Americans aged 2 years or older consume too much sodium. 2 years or older already start consuming too much sodium, which can increase the risk of high blood pressure. So if we take all of those statistics, which there are thousands more, 86% of the nation's 2.7 trillion annual healthcare expenditures are for people with chronic and mental health conditions. If we can manage those 3 lifestyle behavior that lead to the first 3, then we can, of course, cut down costs. So our next one is top 10 chronic conditions. I'm actually going to talk about the 10 most common chronic conditions for adults 65 and older, since Medicare is a big population. Chronic conditions change a little bit, alter once you get into different age groups. But as you can see, hypertension, high cholesterol, arthritis, ischemic heart disease, diabetes, chronic kidney disease, heart failure, depression, Alzheimer's disease, and chronic obstructive pulmonary disease are the top 10 right there. So if we go back and look at that statistic about how much extra sodium we consume with the fast food nation that we're in, 58% of people have hypertension in 65 and older. So if we can start to incorporate these programs that we'll talk about here shortly, then hopefully the goal is to reduce problems that arise and then create more additional chronic conditions. So the first one, chronic for care coordination services, is the chronic care management. I'm not going to go over these in detail, but I just want to share a quick overview. The codes are 99490, and as you can see, following, reimbursements have gone up. So $42, $92 for the complex, or $139 if you do an add-on code and you spend 90 plus minutes on patients that have complex care programs or complex care plans. Then there is a large amount of reimbursement. CMS is pushing these programs so that we can better serve these patients that have these chronic conditions. If you want to learn more information, we can get in touch. There's resources to the cms.org website. The next one is the behavioral health integration, which takes into account the behavioral, mental, or psychiatric health condition that's being treated by any billing physician. A psychiatrist is not required for you to bill this code. Again, this brings into the health coaching piece of it. If you are an FQHC or RHC, there's a different code for you to bill general BHI or CCM, and that's 99484. So let's get into what is health coaching. We want to empower our patients. We want them to gain knowledge, skills, tools, and confidence to manage their chronic conditions and healthier lifestyle habits. We want to help them set and reach self-identified goals, and that self is a very important piece of this. Health coaching and behavior change is all about making them a part of the plan. Many times, physicians, they go in and they have to work on management of a condition. We don't give them an opportunity because we don't have the time many times for them to work on their own goals or talk about their own goals or their own worries. And this is where the health coach and these PCM and BHI programs can really play a positive role or have a big impact. And then lastly, to become active participants in their healthcare while working alongside their PCP and specialists. Integrative model, we want to collaborate with their primary care provider, all their specialists, their counselors, and their chronic care management. We want to bring all these people together. So how do we combine the chronic disease and health coaching? We need to first understand and research all the components of the care coordination services, requirements, the reimbursement, the staff roles and responsibilities, educating the patient. We want to engage the patient, improve outcomes, reduce overall total cost of care, and get reimbursed, which then ties into MACRA and value-based care. And we all know that's the forefront of where we're at because that's the direction that we're moving in healthcare. And lastly, we need software for tracking care plans and billing. And this helps with audits and ease of workflow. So we're moving on to module 2, which is evidence-based behavior change. Again, that's my background, and we all want to know, how do we change? How do you get someone to change? We all have had those frustrating people in our lives, maybe that ourselves, maybe it's a parent, maybe it's an aging adult that you have to care for, and you wonder, how do we get them to change? We're going to give you the tools to be able to do that, at least get started with the most basic. The components are the motivational interviewing, stages of change, and self-efficacy, and helping you to learn those. So we're first going to get into motivational interviewing, which is centered around individual approach where patient steers the path to change while overcoming ambivalence. Ambivalence is the key word for motivational interviewing. That is their hesitation to change. They're ambivalent to changing. There's something standing in the way from getting them to change. So how do we overcome that? Brief history. The principal architects are William Miller and Stephen Rolnick, created through years of research within the addiction treatment field. It focuses on encouraging a change rather than the resistance to change. So this is about a positive mindset. It is not about what they're not doing well, but more about what is going well. The more likely patients make the case for change, the more likely a change will occur. The opposite occurs if the coach tries to make the case for change. The next, there's 4 core principles within motivational interviewing. 1, expressing empathy. 2, developing discrepancy. 3, rolling resistance. And lastly, supporting self-efficacy. So we'll briefly get into those 4. First, we're going to talk about expressing empathy. We all know if someone's empathetic, we want that person in our life. We need those empathy people in our life. Empathy means that we understand a person's experiences, feelings, thoughts, and desires. If you have these Medicare patients that are on 10+ medications, if they're struggling with financial burdens, if they don't have any social support, they need empathy. What they don't need is someone telling them what they need to do. There's a time and a place for that. The health coaching role is all about empathy. We expand awareness, we create openness, and then in turn we facilitate change. The more a patient feels stuck or ambivalent, the more the coach needs to express empathy. Achieving behavior change in patients with multiple chronic conditions must begin with the patient feeling calm, safe, and judgment-free, creating openness and honesty about their feelings, their needs, and their shortcomings without fear of pressure or ridicule. That is so extremely important. Another important factor is the empathy versus pity or sympathy. Empathy is not the same as pity or sympathy. Pity is defined as grieving someone's experience, which may lead to charitable actions, which does not leave the patient feeling empowered. Sympathy is defined as identifying with someone's experience on an emotional level. If you feel sad, I feel sad type of mentality. We don't want to give in to the patient's emotion. We just want to accept them. We want to understand them, and we want to clarify their emotions. You could say, I respect where you are today with your chronic conditions and your health behaviors. The next one is nonviolent communication. We make observations, not evaluations. An evaluation is, I failed to take my medication this week. An observation may be, I took my medication 2 mornings that week. That's flipping it to the positive to say, well, you may not have taken it all week, but you took it 2 times. What was positive about those 2 times? What helped you take your medication? We want to express feelings, not thoughts. I feel useless in controlling my diabetes is a thought, but confused is a feeling. I feel tired because I'm overweight is more appropriate and descriptive. We want to identify needs and not strategies. Identify universal needs, autonomy, connection, honesty, meaning. This gives rise to positive feelings as opposed to feelings such as afraid, confused, disappointed, and sad. And lastly, we want to make requests and not demands. Confirm coach to patient understanding and agree on an action or express words of empathy and understanding. What would you like to be your next step to improve your diabetes? The third one is developing discrepancy. So we want to ask open-ended questions. Make more than half of your questions open-ended. Allow patients to take an active role. If we're asking them yes or no questions, many times we don't get an expansive response. This evokes change talk in the patients. So what are some what and how questions? What's been your best experience with your new behavior change? What concerns you most about your diabetes? How about your current habits impact your future health? On the flip side, if you said, do you feel like you're controlling your diabetes? They may say yes or no, and that's all you get from them. The second piece is the reflective listening. We want to enable our patients to see themselves when hearing aloud from someone else. Repeat verbatim, amplify reflection to get quicker reaction and insight from patient, and double-sided reflections hearing 2 sides from the patient. Verbatim, of course, is you don't have time to exercise, and neither does anyone around you. If you're talking about their diabetes and they say, I just don't have time and nobody around me exercises, you repeat it back to them and they know that they're heard. Amplified might mean you don't know anyone that exercises. It's impossible for you to fit into your schedule. And then they may come back with, well, it's not impossible. I could probably fit it in one day. And then the double-sided is you say you don't have time, but. So those are just some examples. The last one is decisional balance. So this is the pros and the cons and the rulers. These are really great tools that you can use over and over and over again. What are the costs of changing? What are the benefits? And assist in ways to create a change. If you have diabetes, or if you have arthritis, or if you have chronic pulmonary disease, what are the costs if you stay the way you are now? What would happen 5 years from now if you made no changes from today? Rulers are the scale of 1 to 10, confidence, importance, and readiness. Really powerful tools. On a scale of 1 to 10, how important is it for you to change your breakfast? They may say 2. And you say, well, why did you say a 2? And they may go into that. If they are not willing to move their importance level up, then it may not be a good goal to focus on, is their breakfast. You might need to move to something that's more important. This enables the patients to think out loud. It helps them to get to a higher number or recognize it may not be important right now. Rolling with resistance. No one likes to be told to change. Patients need to create and develop the desire to change. Arguing, demanding, diagnosing, fixing, etc. can push the patient away from wanting to change. We probably all dealt with this with our spouse, with our friend, with someone in our family, with our kids. It doesn't work many times. Focus on the connection and not the correction. The more we correct, the greater resistance to change. The more we connect and understand, the more trust and openness occur, leading to change. Focus on confidence, not competence. Believe in patients' ability to change and claim to know less when talking about goals for the patient. Focus on client awareness of ambivalence and less on arguing against what they aren't doing or what they need to be doing. Moving on to self-efficacy, which is actually its own behavior change model, but it's also a piece of the motivational interviewing. It is all about the patient believing they are capable of making a change. We can believe in people all we want, but if they don't believe in themselves, it's not likely going to change. Patients can learn how to learn. So we'll talk more on self-efficacy in the self-efficacy theory. I am not going to get into stages of change too deeply. I feel like it's a very common model that we hear often. And as I go over it, you'll probably say, yeah, I've heard about that, or yeah, I've actually used that. So just a brief history is James Prochaska developed this model based on more than 25 years of research studying behavior change, a multitude of different behaviors varying from smoking, exercise, eating habits, and beyond in clinical and home settings. This model is a blueprint for reaching behavior change while empowering the individual. It creates an understanding of how and when behaviors change and morph, and why there are challenges to make a change. So there's 5 stages. There's pre-contemplation. Somebody is just not ready at all to change. They're a smoker, no desire to change. They say, been doing it for 50 years, no desire to quit. They're contemplating, they're thinking about it, they're preparing, they've already done the research, they're educated, it's becoming important to them, they want to change. Action, they're already taking action. So this preparation and action is really need to grab hold of them and educate them and give them confidence, believe in them, and give them the tools they need. And last of all, maintenance means that they're already doing this and they just need to maintain this. So I'm going to move on to the third one, which is self-efficacy and social cognitive theory. The history is developed by Albert Bandura in 1986 and is still widely used today. It's about human behavior being determined by 3 factors: our personal factors, what we believe, and how we feel we are capable of doing. Environmental factors, what is our support and what is the impact of the people around us. And behavioral factors, what we experience and accomplish. Environmental is about verbal persuasion, what people say to us socially, communicating confidence, reduces self-doubt. Patients may try harder on their set goal. The more we see other people accomplishing or achieving a task or a goal, the more likely we believe that we can do it too. So if you have a diabetes program going on in your clinic and people are seeing results, people are seeing weight loss, and you're hearing patients saying, oh, I'm eating healthier, or I'm taking my medication and I feel so much better, I have a lot of energy, this is going to have a large impact on the other diabetic patients around them. This is one of my favorite quotes, is my certainty is greater than your doubt. It's a good rule of thumb for coach-patient relationship when patient is having doubts. Beware that it is far easier to discourage someone with our words than to encourage them. Be aware of what language you're using with your patients and focus on that positivity. So what affects our self-efficacy? What affects our ability to believe that we can do it? We have our course of action, our effort, our persistence, resilience to adversity, stress, and level of accomplishment. Self-esteem is the bedrock of health coaching. We have to believe in ourselves to be able to make that change. We're going to move on to the clinical health coaching piece of it. So the components are to get to know and understand the patient, identify chronic conditions and subset interventions, create a wellness vision, goal setting, and develop a clinical workflow. The objectives for this module are to have the ability to build rapport and trust with the patient, create a wellness vision that encompasses the overall objective of the program, demonstrate the ability to create SMART goals, which we've probably all heard many times before, and be able to create a workflow plan and utilize the tools and resources available to the patient. Clinical workflow, chronic care conditions and care plan. What chronic conditions qualified the patient for this program? Are you documenting it into any specific software or EMR or EHR system? Do you have a timer? Do you know how you're going to do the billing? What tools, interventions, resources, education services are available for the patient? These are all really important pieces to know before you start to implement the chronic care management or the behavioral health. We want to get the patient background information, demographics, which many times in the clinical setting we have access to that. Social determinants of health. What are the financial burdens, the education, the social support, the transportation? We need to figure out these things because these sometimes are the barriers from them creating the change. We want to do an introduction. We want to give them our expectations, our role as a chronic care manager. Many times these Medicare patients, Medicaid patients, private payers, whatever kind of patient it is, no matter how old they are, they want to feel confident of who you are, get to know you before they feel comfortable talking to you over the phone. Maybe it's a FaceTime call they do within the office, or maybe it's an on-site visit that they do. They want to know your credentials and your scope of work many times. And what are the goals? What's the purpose of them being here? So again, we go back to that build rapport. Ask questions so the patients know that you care. What are your goals in this program, and what questions do you have for me? This all gains the trust. The next is one of the most important pieces that is many times overlooked in a clinical work setting. Let's build a vision. This is a statement that describes our ideal health and wellness. It reflects the feelings, the needs, the values, and desires that can motivate and sustain behavior change. Again, it reflects feelings, needs, values, and desires that can motivate and sustain behavior change. But in and of it themselves do not lead to the behavior change alone. We have to create the vision, and then we have to follow up with goals. So just the definition of wellness is one of my favorite. Wellness is not the absence of disease, but the mastery of one's well-being, physical, emotional, and social and spiritual. Visions are bold. They're stretching beyond the status quo. They're what people truly want. They're palpable as if they are already true. We want to write them in the present tense. We want to write them as in I am from the patient perspective and not I will. Another thing you can think about is sending these visions to the patient so that they see their care plan and they know their vision for participating in this program. So a vision might be, I want to get off my blood pressure medications or reduce my blood pressure medications. I want to be more active and have more energy so I can play with my grandkids. And I want to live 15 more years and not be uncomfortable. That's a vision. Those are not goals outcome goals that they try to figure out. That's the reason that they're setting a goal. And it's really important to have the patient understand what their vision is. So there's 5 parts. There's the values. Who do I want to be and what do I value most in my life? There's a worksheet that they complete. Strengths, barriers, support. So we have value, strengths, barriers, and support. What are your strengths, talents, and abilities that will I draw upon myself? One challenge I have for all the listeners is to ask somebody in their life, what are my 3 biggest strengths? It is one of the biggest confidence boosters that you can get. It's just hearing someone else telling you what they think you're doing well in life. Barriers, what challenges will I overcome? What stands in my way? And my support system, which is crucial to this. What support team and structures will I put in place to help me reach my vision? List 3 people that support me in my life and how they can help hold me accountable. Many times in these settings where we have Medicaid and Medicare patients, they do not have that support system. They may have to think outside of the box. It might be their nurse. It might be somebody that the bus driver where they hop on the bus every day and they can help with accountability. It might be a phone call or a stranger that they have to ask to give them accountability in their life. Next is goal setting. There is a big difference between outcome goals and behavioral goals. More often than not, our patients and people in general will give you the an outcome goal. So an outcome goal is the vision of an outcome, what you want to see happen and the end result. We want to focus more on the behavioral goals, which is the weekly goals and action-based. So an example of an outcome goal is, I want to reduce my blood pressure. That is not a behavioral goal. How do we reduce our blood pressure? It may be, I am going to eat a healthier breakfast by adding a fruit into my morning routine and stop eating McDonald's for breakfast every morning, which is high in sodium. So that is something they can measure and they can go back to and they can hold themselves accountable. In the beginning, like I said, many patients will know more about what they want, the outcomes, than how to get there. Behavioral. We have to work towards that behavioral goal. As the health coach, you will coach them through the process. So then we move on to the goals piece of it. There's weekly goals, there's 3-month goals, SMART goals, and the outcome and behavioral goals, which we just talked about. Weekly goals, you might set 2 or 3 weekly goals with them if you talk to them once a month. A 3-month goal is that a little bit expansive. So we want to see where we want to see ourselves 3 months from now so we can go back and see if we've made that progress. And then the SMART goals is things that we have often heard: specific, measurable, action-based, realistic, and timely. I want to end with the health coach toolbox. And I'm just going to run through some things that can be helpful in doing this health coaching in the clinical setting. Remember the best experiences in the past with healthy habits. What healthy habits do you have, and why are they healthy habits? And they may say, well, it's important to me to brush my teeth every day because I don't want to lose my teeth. And so you can build on positive experiences by simple things, just like habits like brushing your teeth. Identify core values and tie this to the goal. Brainstorm possibilities before setting goals. Work with them to come up with creative ideas and then let them come up with the solution first. The weigh the pros and cons, which is the decisional balance. Rulers, they use the readiness, confidence, importance scale. Ask why they chose that number and what would get them to a higher number. Describe to me what it would be like in a perfect world. That can be refreshing in and of itself. Sometimes if someone asks you, if they give excuse after excuse after excuse, you can say, in a perfect world, what would this look like for you? And just describing it can sometimes bring on relief and confidence in them to say, wow, I said that out loud. That's what I want to happen. How can I make that happen? Reflect back, repeat what the patient said verbatim or summarize it. Ask open-ended questions that create greater clarity, possibility, or new learning. What do you want to accomplish? What have been your best experiences? What values do you have that you can align with this goal? And for whom do you want to make this change? It's important they want to make the change for themselves. Sometimes they may want to make this change for a spouse or for a child. And that's okay if that's where you start. Patient goal and care plan review. We want to review at the end of every session, whether it's 20 minutes or 60 minutes we're spending with this patient. It is best to start by asking the things that went well and what was learned rather than what wasn't accomplished. The review is actually done at the beginning of the call from the last time you talked to them. This aids in the coaching process and builds self-efficacy and confidence. These are some of the same questions that I talked about before. As you can see, a theme. Repeating the same tools and using these can be really effective. The last thing that I want to talk about is resilience. And studies have shown that resilience is the single most important skill that you can develop to be happier, healthier, and more successful. So if we're able to bounce back from hardships in life, from adversities in life, from financial burdens, from stress at home, from not having social support, these are 4 things that you can do to build resilience. Because resilience isn't just part of us, it can change. We can build resilience, which then can help with behavior change and self-efficacy and confidence. There's 4 pieces to resilience, and I'm going to let you all participate at home. Number 1 is physical resilience. If you can raise your hands above your head for 3 seconds, go. Please do that. So just moving every single day can build your resilience. That's just being active, moving, standing up from your desk, doing some stretches, even taking deep breaths. We need to move more. Sitting still is a killer in life. I don't know if you've heard the new sitting is the new smoking, but sitting is a big part of what we do in our lifestyle today. Just find a way to move more. Mental resilience. Snap your fingers 30 times or count backwards from 100 by 7. You can do it quietly or you can try it. I'm going to give you a few seconds to do that. So mental resilience. Willpower is like a muscle. The more you use it, the stronger it gets. If you tackle a tiny challenge without giving up, you increase your mental resilience, discipline, and determination. The third task, emotional resilience. Quick, do a Google search on baby your favorite animal. Oftentimes, if I was showing this to you on the slide, you might hear some oohs and ahs, right? Babies bring this calmness about us. Curiosity and love are just 2 of the emotions you can learn to provoke anytime, anywhere. If you manage to experience 3 positive emotions to every 1 negative emotion over the course of an hour, a day, a week, you dramatically increase your emotional resilience with that 3-to-1 ratio. A good number to remember. The last one is social resilience. If you're not with somebody, you might not be able to do the first one, but shake someone's hand for 6 seconds or send a quick thank you or thinking of you text to your friend or family. When you shake someone's hand for that amount of time, you are biochemically primed to begin to trust and like one another. You can use that at the office on someone if you do this little trick. sending a quick thank you or thinking of a friend, or tell a friend or a family that you're thinking of them, can dramatically raises your oxytocin in your bloodstream, the trust hormone. By regularly boosting these 4 resiliences, physical, mental, social, and emotional, you can actually boost your lifespan by 10 minutes. There's a TED Talk by Jane McGonigal on that. That's really neat if you guys want to go ahead and do that. We are going to end with evaluations. Of course, this is a very important piece of any program that we do. We want to evaluate our progress. We want to give surveys out to our patients. We want to do pre and post assessments, and we want to have the data, the analytics, and the reporting. So we want to identify key outcome markers, assess success qualitatively and quantitatively, I repeated that, utilize software and technology for data analytics and reporting, be able to analyze trends, and use reporting, survey feedback, assessments to show program effectiveness. Effectiveness with collaborative care between patient, care coordinator, and health coach, physician, primary care writer, and specialist. There's a diagram and workflow chart that you can use that I showed earlier. Oh, I guess it's not a diagram, but you can create your own. Impact evaluation. Has the program brought about significant changes in knowledge, attitudes, and health practices within the patient? Measures whether goals of the program are being accomplished. If we don't evaluate, we have no idea the success of the program. And then the process evaluation helps to identify the causes of the program, strengths and weaknesses to indicate modifications that are needed to improve the program. So these are some of the resources that I use: the Coaching Psychology Manual, CDC, and the National Council on Aging. So that is all I have for today. So thank you for tuning in. And Allie, I'm not sure if we do a Q&A or if it's just saved for later and they can go back and have access to this. Allie, are you there?
Yes, I'm sorry. I had both my phone and my computer muted, so I was just chatting away.
Oh.
We definitely will do a Q&A right now. If people have questions, they can either unmute their line or use the chat function, which will be either at the bottom or top of the screen, depending on whether you have Katie's screen in full screen mode or not. In the meantime, Katie, I know you're planning to work on some deep dive kind of presentations into some of these other modules. Do you want to provide your email address if anybody is interested in learning more about health coaching on a more in-depth level, and they would be able to email you whenever they're ready? It would kind of give you some contact information.
Yeah, absolutely. My email is kconner, KCONNER, at indianarha.org.
Excellent. Thank you so much. And then also, I do want to let everybody know that our ability to put on these free lunch and learn programs is contingent on grant funding. So if before you leave today, you could just send us a quick text of what facility you're representing, especially if you're from a critical access hospital. We need to know that. It's very, very helpful for us to continue to pursue funding to put these on for everybody. And I'm also going to include a link right now in the chat where I see Heather has shared with everyone Katie's email address. But I'm also going to share the link to our SurveyMonkey. Just a quick follow-up, won't take you more than 2 minutes to complete, but it's also very important for us to get this data to be able to continue these kinds of programs. And my last plug will be that if you check our website, that's indianaruralhealth.org, we have several upcoming lunch and learns that are really, really great, and we'd love to see everybody back for those. Heather has also shared that email address. But at this time, any questions for Katie, go right ahead, either in the chat function or you can ask by unmuting your line.
Hi, Katie. This is Jim Miller. I really liked your presentation. I have to ask, in my own situation, one of the biggest problems I'm having is just being patient in my recovery. I want to be back to normal, but I'm not. How would you talk to health coaches to kind of slow you down and just say, hey, you got to follow the course of treatment appropriately and not get ahead of yourself?
That's a great question, Jim. I think that it is small wins. So focusing on one step at a time, utilizing your social support and staying positive and talking about the things that I did, small wins. If you can't do the bigger things, take small steps to get to the next step and then the next step. And then you're going to be at your end goal, and just have that vision at the end sight, have your end goal and what you want, and then create small steps to get there one step at a time, and utilize your support system to get there. Talk about it, write about it. Sometimes support system's not always talking. Sometimes it's writing it down can be really powerful. Sometimes it's listing, 3 things you're thankful for in the day when you feel like there's nothing more that you can do, or you're feeling hopeless or helpless. Sometimes that can be helpful too.
That's good. Thank you very much.
Anyone else? Questions for Katie? And again, please do shoot me in the chat function the facility you are representing today. Okay, Katie, it sounds like you've answered every possible question anybody could have, so we really do appreciate you taking the time today to put the presentation on for us. I know we will be seeing more from you in the upcoming weeks and months in the Lunch and Learn program. Heather has shared my email address with everybody. This is Allie Orwig, again, from the Indiana Rural Health Association. If you have any questions or need any follow-up information, you can always contact me there at aorwig@indianarha.org. And without further ado, we will go ahead and end today's presentation. Thank you again to everyone involved.
Thank you all for listening.